Good evening, everyone. Thanks for joining. Today, I will be talking on optimizing diabetes care and the insulin glargine and its clinical profile. So, on 2022, the Banting and the Best and their colleagues developed the first insulin molecule, which has been introduced to the clinical usage. Almost after 2 decades, our NPH was introduced. The NPH brought so many clinical benefits, but it came with limited restrictions. One such thing is midnight crash, a dangerous nocturnal hypoglycemia pattern that haunted patients and clinicians for decades. Almost 23%, which is one in every four patient developed symptomatic nocturnal hypoglycemia. So that signals the need of long-acting insulins. That is how the Glargine entered the market. So Glargine entered the market with a simple yet strong promise, that is once daily 24-hour steady insulin action, and more importantly, it delivered on that. So within the first 2 years of its launch, over almost 1.2 million patients had transitioned to the Glargine. So that implies the unprecedented clinical confidence and patient demand. So the elegance of Glargine begins with its molecular architecture. The special biochemical property of Glargine is it is soluble in acidic pH and it gets precipitated in neutral pH. So if you ask me, is it the disadvantage of Glargine? No, it is the advantage of the Glargine because it is soluble in acidic pH, but upon injecting into the subcutaneous tissue, it forms a microprecipitate, which is slowly introduced into the circulation. So that is how it acts for 24 hours without any peaks. So on day one itself, it maintained the gradual plateau without any spikes, unlike your NPH. With that, we can titrate the glargine according to the glycemic profile of the patient. So coming to the efficacy of glargine. So it is based on the pooled RCT evidence, which was conducted over 3 years, around 2022 to 2025. Almost it involves 7,200 patients. In that, the glargine delivered a mean HbA1c reduction of 1.22% from the baseline, which is clinically meaningful reduction. So apart from reducing the HbA1c, the total requirement of glargine is comparatively less comparing with the NPH. Almost 10% dose reduction is needed for glargine. So coming to the safety profile of glargine, there is 30% reduction in nocturnal hypoglycemia comparing with the NPH. So apart from reducing the nocturnal hypoglycemia, there is also reduction in severe events like emergency room admits. So what is happening in the real world with the glargine? It is based on 2024 registry data, which includes almost 5,600 patients who has been shifted to glargine from NPH. So they have been observed for hyperglycemia. There is 45% reduction in hypoglycemic episodes within 6 months of initiation of glargine. So almost 22% reduction in the emergency admissions. So glargine is not only used in adults, it can be used in pediatrics also in the age of 2 years or more than 2 years. So in 2022, FDA approved glargine for pediatric usage. So we have evidence for pediatric usage with this case study of Mia, who is 7 years old, type 1 diabetes, who achieved an HbA1c reduction of 7.4% within 4 months of initiation of glargine. So glargine, apart from its usage in pediatrics, it can be safely used in elderly people and patient who is having pre-existing renal compromise. But what is important here is we have to start with the 30% dose reduction of glargine. Unlike normal patients, we have to reduce 30% of the dose with slow up titration with the frequent monitoring of glycemic profile. There is a study, I think it is a pilot study conducted on 2024, which involves 1,200 elderly patients with renal impairment who has been started on insulin glargine, showed no increase in severe hypoglycemia. So that validates our guideline directed dose modification of glargine and its safety profile. So coming to combination of glargine with GLP-1 analogs. This is based on a dual trial conducted on 2023. So what is happening here is that glargine is combined with the GLP-1 receptor analog, that is liraglutide. So apart from reducing the HbA1c, it also reverses the weight gain, which is happening with glargine. So while combining with liraglutide, there is a reduction of weight around 1.5 kg. So one important thing is glargine is it provides peakless 24-hour action, so which has been evidenced by ProSafe trial, which was conducted on 2024. What they have done is they used a scale. The patient should mark the fear scale of hypoglycemia in that scale. So which was monitored for 3 months. So after starting glargine, within 3 months, there is a 40% reduction in fear of hypoglycemia. Moving on to cardiovascular safety of insulin glargine. This is based on meta-analysis, which involves 12 RCTs, which includes almost 19,000 patients. What is happening is, apart from reducing the HbA1c, there is a neutral cardiovascular safety glargine, which means so we are providing better glycemic profile without hypoglycemic episodes, not at the cost of cardiovascular safety. So the hazard ratio for MACE was only 0.98%. So it can be safely used in patients with cardiovascular diseases. Coming to the weight profile, comparing with Dechimer, the isolated glargine use is associated with 0.3 kg weight gain, which is very clinically marginal. But the special thing is glargine with its once daily dosage, peakless profile, it outweighs the benefits of Dechimer. So when to start glargine? Any patient who is having uncontrolled hyperglycemia with the HbA1c of more than 8%, not controlled with multiple drugs, you can very well start them on glargine, but we should be cautious if the eGFR is less than 50. You have to reduce the dose by 30%. So how to initiate and how to titrate insulin glargine? That is 2-unit weekly steps. So we have to start insulin glargine at 0.2 units per kg once daily, and we have to uptitrate 2 units every 7 days if the fasting blood glucose is more than 130 milligram. If the fasting blood glucose is falling below 80 milligram, we have to reduce the dose by 2 units. So this is the often faced clinical scenario. What should we do, sir, if we miss the dose? So it is based on the duration. If it is less than 12 hours, they can take the next dose as soon as they have remembered it. If it is more than 12 hours, better to skip that dose and they can resume the next dose as per the scheduled. So skipping is always safer than doubling. So till now we have discussed all the clinical data. Hereafter, I will discuss 3 cases. One is Mr. John, who is a 58-year-old male having long-standing diabetes, who was on NPH insulin, struggling with hyperglycemia, frequent hyperglycemia. He was started on insulin glargine. Within 6 months, his HbA1c was reduced to 7.1% from 9.2%. Without any hypoglycemic evidence. So he had better sleep without any fear of hypoglycemia. Next case is another male, he is 58-year-old, he is taking metformin, DPP-4 inhibitors and SGLT2 inhibitors with the maximum tolerable dose. Despite taking all this, his HbA1c was 8.8%, and his fasting blood glucose was 168 milligram. So he was started on insulin Glargine. Within 2 months, his HbA1c was reduced from 8.8% to 7.3%, and his fasting blood glucose is now 112. So what is special is he didn't develop any hyperglycemic episodes. He was very much satisfied with our simpler regimen. So our third case is a 68-year-old male with type 2 diabetes with documented coronary artery disease. And his blood sugar was inadequately controlled on oral therapy. His HbA1c was 8.2% with the maximum tolerable oral doses. What we have done is we started him on insulin. After 12 weeks, his HbA1c was improved to 7.1% without any cardiovascular symptoms or hospitalization, and his weight was stable throughout the therapy. So this demonstrates the clinical safety of Glargine in cardiovascular patients with cardiovascular diseases. So our Glargine is not only used in pediatrics or elderly, it can be used in pregnancy very safely. It is based on International Pregnancy Registry 2023, which includes around 2,100 pregnancy patients, so who are all started on HbA1c and monitored for any congenital anomalies. There is no increase in congenital anomalies, and the mean HbA1c reduction of 0.8% during the treatment. And the beauty is they had maintained the glycemic control throughout the pregnancy without any glycemic variation, without any hypoglycemic episodes. So key takeaway is our Glargine is it is peakless 24-hour acting insulin with a 30% reduction in episodes, and there is a significant HbA1c reduction of 1.22%, and it is very economically affordable, and it is very well accessible in almost all the cities and rural areas. To conclude, with its better clinical profile, affordability, and accessibility, the Glargine can be the preferred first-line long-acting basal analog in many clinical settings. So the Regenix introduced the Glargine in the name of Sustaglar, which have been used by many clinicians across India. So they have compared the Sustaglar with the innovator molecule, and the study population is both type 1 and type 2 diabetes. The endpoint is non-inferiority of HbA1 reduction comparing with the innovator molecule. So the fasting plasma glucose control and hypoglycemic evidence are no better than the innovator molecule, and there is no significant difference in insulin antibody formation. So our Regenix not only providing insulin, they are also providing patient education toolkit, which includes interactive dosing calculator, so the patient can measure the insulin requirement based on their weight with this tool. They have also provided video tutorials, how to use pen device, how to inject insulin step by step. So everything is explained in the video. To conclude, uh, Glargine with its safety profile without the hypoglycemic episodes, with its affordability and widely penetrated distribution, we can very well use Glargine without any fear in all the needed patients. Yes, thank you, sir.